Welcome back to the Deep Dive. You know how we do it. We take the most complex research, the densest stack of clinical sources, and we distill the absolute core insights into a conversation that helps you get truly well-informed. Today, we are tackling a critical topic in emergency medicine, one that has profound implications for millions of people who live with severe allergies. We are plunging into the revolutionary development of the epinephrine nasal spray, Neffy. And this is a potential game changer because it addresses the single biggest behavioral barrier to life-saving treatment, the needle.
That's absolutely right. And the stakes couldn't be higher. Anaphylaxis is a severe, life-threatening allergic reaction. Our sources confirm that this condition affects somewhere between 1% and 5% of the U.S. population. That's millions of people. And the medical community has been unified for decades. Immediate administration of epinephrine is the only universally recommended first-line treatment. There is no plan B.
So our mission today is to deep dive into the clinical data supporting Neffy's recent FDA approval. We really need to understand the development, the pharmacokinetics, or PK, and the pharmacodynamics, the PD, of this needle-free alternative. We have a whole stack of sources that compare Neffy directly to the established standard, the epinephrine auto-injectors, or EAIs, and we need to get into how the developers proved it was comparable without running what would be some very unethical efficacy trials.
Exactly. And the core problem we're addressing here is this critical disconnect between having a prescription and actually using it. While EAIs, EpiPens and their competitors contain this life-saving medicine, their effectiveness in the real world is severely limited by non-adherence.
Tell us more about those barriers. Why are these devices, which have saved countless lives, so often ineffective when patients need them most in a community setting?
It's a multi-layered issue of adherence and utility, and it starts right at the pharmacy. Our sources highlight that prescription fulfillment rates are surprisingly low.
So people get the script from their doctor, but just don't pick it up.
They don't. And even if a patient gets the device, studies show fewer than half carry it consistently. But the most devastating failure point, the one that leads directly to failure or delay in use, is psychological.
The needle.
It's primarily driven by needle phobia. And this affects not just the patient, but often the bystander or the caregiver who is tasked with administering this injection under extreme duress.
We've all seen the hesitation, even for a simple blood draw. To ask a panicked parent to handle a sharp spring-loaded object and jam it into their child's leg, that is a massive psychological and, frankly, technical barrier.
And that delay, even by a minute or two, is catastrophic. Delayed or failed treatment is strongly associated with an increased risk of biphasic reactions, prolonged hospitalization, and, tragically, death.
What's a biphasic reaction for our listeners?
It's when the initial symptoms of anaphylaxis improve, but then a second wave of symptoms comes back hours later without any new exposure to the allergen. It's incredibly dangerous because people think the emergency is over.
So that immediate intervention window is short and absolutely vital.
It is. The clinical course is just too unpredictable.
Okay, so Neffy steps onto the stage offering this truly innovative, needle-free route of administration. It's approved in a 2 milligram dose for adults and children who weigh 30 kilograms or more, and a 1 milligram dose for kids aged 4 and up, weighing between 15 and 30 kilos. This innovation, if the science holds up, could drastically increase the rate of prompt treatment. Okay, let's unpack this. Let's start right at the beginning with the life-saving molecule itself.
Yes, we have to begin with the mechanism of action. Epinephrine, or adrenaline as it's also known, has been the foundation of allergic reaction treatment for over a century. It's a sympathomimetic agent, essentially a non-selective agonist that hits both the alpha and beta adrenergic receptors all over the body.
And that broad simultaneous action is why it's the only drug that can effectively counter the multi-system chaos of anaphylaxis.
Precisely. It's a full-body reset.
So let's break down that chaos and how epinephrine specifically counters it. Anaphylaxis causes massive systemic vasodilation, right? Your blood vessels just widen dramatically.
Exactly. And that leads directly to a sudden catastrophic drop in blood pressure. That's hypotension and eventually circulatory shock, which is often the fatal event.
So how does epinephrine stop that?
When epinephrine activates the alpha-adrenergic receptors, it causes powerful vasoconstriction. It literally squeezes the blood vessels.
So it's like turning up the pressure in the system.
It is. It reduces that dangerous vasodilation. It increases what we call peripheral resistance, and it immediately begins to correct the hypotension. You are quite literally shunting blood back to your core organs to prevent shock.
Okay, that addresses the circulation crisis. But then there's the severe respiratory distress, the bronchospasm, the swelling, the wheezing.
And that's where the beta-2 adrenergic receptors are absolutely essential. Activation of beta-2 relaxes the smooth muscle lining the airways.
So it opens up the lungs?
It alleviates the bronchospasm, the wheezing, and the difficulty breathing. And there's a critical secondary effect here. Epinephrine also stabilizes mast cells.
Those are the immune cells that are freaking out and releasing all the histamine, or...
The very ones. It prevents them from dumping more inflammatory mediators into the system.
So it's both a treatment for the current symptoms and it's a preventative measure against things getting even worse.
Exactly. It's stopping the fire and taking away the fuel at the same time.
And finally, the heart. What's happening there?
That's the beta-1 adrenergic receptors. That's where epinephrine improves cardiac output. It increases the heart rate and it strengthens the force of the heart's contraction.
So it makes the heart beat faster and stronger.
Right, helping to maintain adequate blood flow despite all the widespread circulatory issues. You can see why it's called a physiological reset button. It hits all the major life-threatening parts of the reaction at once.
It's a miraculous drug. But as we established, it's been hampered by its delivery system, the EAI. Let's dig a little deeper into the burden these devices have placed on patients.
Well, historically, there was a major assumption built into the regulatory pathway for these EAIs. The sources point out that products like EpiPen, Alvi-Q, and the generics were often approved based on the assumption of pharmacokinetic equivalence to a manual IM injection.
You meaning they just assumed that if the device got the drug into the muscle, it was good enough? They weren't really tested in big efficacy trials against actual anaphylaxis?
Precisely. But what's interesting is that recent studies have revealed notable pharmacokinetic variability even among the different approved auto-injector products.
So not all EpiPens are created equal, so to speak.
It complicates that initial assumption of perfect equivalence. For you, the listener, this means that even if you're doing everything right with an EAI, you might not be getting the exact same drug exposure depending on which product you have in your hand.
And then we come back to that utilization failure. I just can't get over that statistic.
In one study of patients prescribed EAIs who had a reaction, only 30% actually used their device. That adherence gap is just stunning.
It is the definition of an unmet medical need. And besides the psychological barrier of the needle, there are practical obstacles. EAIs are bulky. They're difficult to conceal or carry, especially for kids or during sports.
And the replacement burden, too.
A huge factor. They typically have a limited shelf life, often requiring replacement every 12 months. That contributes to high lifetime cost and, logistical failure if you miss the expiration date.
So the case for needle-free delivery seems overwhelming. Not just for comfort, but for actual compliance. Intranasal administration, beyond just avoiding the needle, must offer some other advantages. What are they?
Well, the IN route offers really rapid absorption because the nasal mucosa is highly vascularized.
Meaning it's just rich with blood vessels ready to pick up the drug. Exactly. It's easy to use, and as we've said, it avoids the pain and anxiety of injections. And this isn't a new concept. Intranasal delivery is already a proven, reliable route for other emergency out-of-hospital drugs.
Like what?
Things like naloxone for opioid overdose, midazolam for seizures, sumatriptan for migraines. The pathway is well established.
So the concept is proven, but delivering epinephrine, which I understand is a relatively large molecule that the body doesn't absorb easily, that must have been a challenge, which sets us up perfectly to examine the technology Neffy had to overcome.
Absolutely. The developers achieved this injection-like speed through the nose by integrating 3 key, already FDA-approved components. The sources are calling it the proven triad.
Okay, component 1 is the active ingredient, epinephrine. Simple enough. Tell us about the secret sauce component 2.
That would be the proprietary absorption-enhancing agent. It's known as Intravale, or by its chemical name, dodecylmaltoside, DDM.
Intravale.
This is the technological cornerstone that makes rapid systemic absorption through the nose possible for a molecule like epinephrine.
Okay, so how does Intravale chemically manipulate the nasal passages to get this speed? Because, normally the body's natural barriers are incredibly effective at keeping large molecules out of the bloodstream.
That's the brilliance of it. Our cells are linked by structures called tight junctions. They create what's called transepithelial electrical resistance, or TEER.
It's basically a highly effective biological seal.
A perfect way to put it. Intravale, which is an alkyl-saccharide, works by temporarily, and very importantly, reversibly loosening these cell-to-cell tight junctions.
It effectively opens a temporary safe gate.
Precisely. It induces a rapid, reversible decrease in that tier, physically opening a pathway through the mucosal barrier. This dramatically facilitates rapid absorption and significantly improves the bioavailability of epinephrine.
That is the real mechanism nugget right there. And this must have implications for safety and side effects too, right?
It absolutely does. This mucosal enhancing mechanism is key to dose optimization. Because the absorption is so efficient, the developers could use the lowest possible dose of epinephrine to get a therapeutic effect.
Which minimizes the risk of overdose or other issues.
Exactly. Importantly, it minimizes dose-limiting toxicities. For instance, very large doses of epinephrine delivered via inhalation have been associated with GI side effects, like abdominal pain, nausea, and vomiting. By maximizing the efficiency of the dose, Neffy mitigates those peripheral risks.
Okay, so we have the drug and the enhancer, and component 3 is the vehicle, the physical device that delivers the dose reliably.
That is the unit dose spray, or UDS. This device is engineered for precision. It's designed to maximize delivery specifically to the nasal turbinate, which is the ideal absorption site. It does this by producing droplet size precisely between 20 and 120 micrometers.
And it has to be reliable. In an emergency, you can't have a device failure.
It is non-negotiable, and this UDS is highly reliable. It's the same type of delivery system used for medications like Narcan, and it boasts a proven real-world failure rate of less than 1 in 100,000 uses. It meets that standard.
Now that we know the components, let's quickly run through the practical perks for the listener.
All right, so the approved doses are 2 milligrams for larger patients and 1 milligram for smaller children. It's sold as a single-dose spray in a double pack.
Which allows for that second dose if symptoms persist after 5 to 15 minutes, which is consistent with the current EAI guidelines.
Correct. And the practical advantages are huge. A long expected shelf life of 30 months, that's 2.5 times longer than many EAIs, and no special storage requirements.
Temperature stability. That seems like a massive deal.
It's a game changer. It remains stable even up to 50 degrees Celsius, which is 122 Fahrenheit.
So you can leave it in a car in the summer or in a backpack during a hike without worrying that it's going to degrade. That alone removes a major adherence barrier.
It absolutely does.
Okay, let's address the elephant in the room regarding regulatory approval. We keep saying there were no efficacy trials, and this often makes listeners skeptical. We need to clearly explain the regulatory standard that allowed Neffy to pass muster with the FDA and the EMA.
It's a really important point. As we mentioned, clinical efficacy trials for epinephrine and anaphylaxis are uniformly deemed unethical and impractical.
Right. Unethical because you can't induce a potentially fatal condition in someone and then maybe give them a placebo, obviously. But why impractical?
Impractical because anaphylaxis is so unpredictable. The variability in severity and triggers in the speed of onset, it means you would need an absolutely enormous group of patients to generate statistically powerful results. And since the efficacy and safety of epinephrine itself are so historically well established, regulatory bodies rely on a standard of comparative data in healthy subjects.
So the mission for Neffy's developers was to prove that their device delivered comparable bioavailability, the PK, and comparable physiological effects, the PD to the already approved IM injection products.
That is the exact core standard. Neffy's 8-year development process involved this rigorous back and forth with regulators, running multiple clinical trials under diverse, simulated real-life conditions to prove that it meets, or in some cases exceeds, that comparability threshold.
Okay, so the moment of truth, the data. Before we dissect the numbers, let's quickly refresh those key terms for our listener who might be, prepping for a meeting or just trying to catch up on the science.
Good idea. Pharmacokinetics, or PK, describes what the body does to the drug. It's about absorption, distribution, metabolism, and excretion. We're mainly concerned with drug concentration and exposure.
And we measure that with things like Cmax, which is the maximum concentration, and AUC, the total exposure over time.
Correct. And pharmacodynamics, or PD, describes what the drug does to the body. That's where we measure the physiological effects, the changes in blood pressure, heart rate, and so on.
Perfect. So starting with PK exposure and speed, what did the pooled study show about overall systemic exposure, the AUC, compared to a traditional 0.3 milligram EAI?
The results were quite compelling. They show that Neffy is not just comparable, but potentially superior in its overall exposure. a pooled analysis, which used a slightly higher dose of a competitor ENS that was in development.
Yeah.
It was a 13.2 milligram dose. They found that the total exposure over 6 hours, the AUC 0360, was significantly higher with the nasal spray.
How much higher?
We're talking 155% to 159% greater than the 0.3 milligram IM auto-injector. And on top of that, the nasal spray maintained the plasma epinephrine concentration for a much more sustained period.
Wow. 155% greater total exposure. That is a massive difference. That suggests the overall bioavailability through the nose, thanks to that DDM enhancer, is just exceptionally good.
It's remarkably efficient.
So what about speed of onset, the Tmax? Anaphylaxis is a race against time. Did the injection still win the speed contest?
In the most critical sense, no. The speed was comparable, though the profiles were different. For that 13.2 milligram ENS, the median Tmax, the time to reach maximum concentration ranged from 20.1 to 25.1 minutes.
And the IM auto-injector?
The auto-injector achieved Tmax at 20.0 minutes, so the peak concentration timing is essentially the same.
But if we look specifically at the approved Neffy 2 milligram data versus an EpiPen 0.3 milligram, what did that exposure profile look like?
This is a crucial nuance. The injection method provides the highest concentration right up to the 20-minute mark. It gives you that immediate high spike.
The classic peak.
Yes. But after 30 minutes and all the way out to 6 hours, the Neffy concentrations were greater than the EpiPen concentrations.
So the injection hits a slightly faster, higher peak, and then it fades quickly, while Neffy builds efficiently to a strong peak and then sustains that therapeutic level much, much longer. It's more of a plateau effect.
That's a perfect description, and that sustained level could be extremely beneficial in preventing those biphasic reactions we talked about, that recurrence of symptoms hours later when the initial dose has worn off.
Absolutely. The sustained presence of the drug seems like a major PK advantage of the intranasal route.
It is.
Okay, now let's move to the PD side, the physiological response. This is what actually matters in an emergency, reversing the shock. How did Neffy affect blood pressure and heart rate?
The response was both rapid and sustained. We saw the pharmacodynamic response on systolic blood pressure, or SBP, that's the top number start, as early as 1 minute after Neffy administration.
1 minute, that's fast.
Very fast. And it persisted strongly for the full 120 minutes of observation. The SBP increase was less abrupt than the IM injection spike, but it was ultimately more pronounced over the full observation period relative to the EpiPen.
That rapid onset is so key. Seeing an SBP change within 60 seconds is crucial for acute intervention. But I read that the diastolic blood pressure, the DBP response, was dramatically different. Can you explain why this distinction is so important?
Yes, this is where we see the distinct pharmacological signature of the different delivery routes. When you deliver epinephrine directly into a muscle with an IM injection, it causes localized activation of beta-2 adrenergic receptors,
Which are highly abundant in the muscle's blood vessels.
Correct. And beta-2 activation causes vasodilation, a widening of the vessels. This results in a measurable decrease in DBP and overall peripheral resistance.
So the injection itself causes this brief, weird side effect of vasodilation in the muscle before the overall vasoconstriction from the alpha receptors takes over systemically.
That's exactly what's happening. But Neffy, delivered via the nasal mucosa, completely avoids that intense localized beta-2 effect in the muscle.
And so
Neffy resulted in a less pronounced decrease in DBP, and in some cases even an increase. It's consistent with having much less beta-2-mediated vasodilation in the skeletal muscle compartment compared to a direct IM injection.
fascinating. It just changes the overall balance of receptor activation. What about heart rate, pulse rate, or PR?
Again, we see that sustained effect. The mean PR increase for Neffy persisted throughout the entire 120 minutes of observation, mirroring its sustained plasma concentration.
Whereas the EpiPen.
The EpiPen or IM injection caused that initial spike in heart rate, followed by a much quicker decrease back toward baseline.
Now, here's the perplexing part that we need to unpack thoroughly, because it really flies in the face of classical pharmacology. The correlation question. If epinephrine works by hitting receptors to raise BP and HR, why did the study show only a weak correlation between the measured plasma concentration and the physiological effects?
It is genuinely counterintuitive, and it's a critical point. The studies showed a weak yet statistically significant positive correlation between the plasma concentration and heart rate. The R value was about 0.32.
Okay, so weak, but there. What about blood pressure?
The correlation with SBP was not significant. This suggests that just looking at the amount of drug in the plasma at any given time doesn't reliably predict the extent of the physiological response you're going to see.
Why? I mean, if the drug is in the blood, shouldn't it be hitting the receptors and doing its job?
There are several complex physiological reasons for this decoupling, and it's observed with all epinephrine devices, not just Neffy.
Okay, so this isn't a Neffy-specific problem.
Not at all. First, the action of epinephrine is often local and immediate. For example, some vasoconstrictive effect might happen at extremely low concentrations in the tissues way before those concentrations are high enough to be accurately reflected in the bulk plasma Cmax.
So the effect happens before the measurement really peaks.
Yes. Second, the receptors themselves can saturate quickly. Once the alpha and beta receptors are activated, just raising the plasma concentration further might not increase the physiological effect in a linear way. There's a ceiling.
So the therapeutic effect happens very fast and perhaps locally, while the peak concentration reading, the Cmax, comes a bit later.
Exactly. And third, and I think this is the most important point, remember these trials are conducted in healthy volunteers. Their bodies are actively trying to maintain homeostasis.
They're fighting the drug.
In a way, yes. They're using their own counter-regulatory mechanisms to oppose the pharmacological effects of the epinephrine. In a person actually experiencing anaphylaxis, those counter-regulatory forces are overwhelmed. Their physiological state is chaotic, which likely allows the drug to exert its PD effects more freely and efficiently.
Which would explain why the PK data in a healthy subject seems so weakly correlated.
Yes. It simply highlights the high interparticipant variability we see across all device testing in healthy people.
That high variability in healthy subjects raises the big question. Will this device actually perform when the patient needs it most? Under stress, possibly with a stuffed nose, or in a state of circulatory collapse. The regulatory pathway rightly demanded testing under these real-life conditions, and this is where Neffy's case gets really strong.
Let's start with the usability test. Self-administration. This was a critical trial. It compared self-administered Neffy 2.0 milligrams versus a healthcare provider, an HCP, administering a 0.3 milligram IM injection. And the subjects were adults who had known type I allergies.
So this simulates the real-world scenario where the patient is the one responsible for using it. What happened when the patient gave themselves the dose?
Self-administered Neffy resulted in higher overall epinephrine exposure. And here's that stunning detail. Neffy resulted in a significantly faster median Tmax 30 minutes versus 45 minutes for the HCP-administered IM injection.
Hold on. The patient giving themselves the nasal spray was faster to peak concentration than a trained professional giving an injection. How is that even possible?
This is a massive aha moment for clinical adoption. The hypothesis is twofold. First, the efficiency of the delivery system is just superior because the patient experiences zero hesitation.
No fumbling with the auto-injector, no psychological barrier, no need to find the right spot on the thigh.
None of that. And second, the nasal cavity is just a remarkably rapid absorption site. The self-administered Neffy also resulted in a greater mean increase in SBP, DBP, and PR, with responses observed as soon as 1 minute after administration.
That data effectively demolishes the argument that patients won't be able to administer the device correctly under pressure. The psychological relief of no needle appears to just expedite the entire process.
It absolutely does. Now, the next major concern was nasal congestion. What if the patient has a cold? Or worse, their allergic reaction is already causing nasal edema and rhinitis.
Two conditions were tested, right? First, congestion from an upper respiratory tract infection, a URTI, a heavy cold.
Yes. The study found that active URTI symptoms, including noticeable congestion and edema, had only a minimal impact on Neffy's absorption kinetics. There was no clinically significant change in maximum exposure, the Cmax, or in the PD response like heart rate.
So it punches right through the congestion.
The absorption was robustly maintained.
Okay, and what about congestion caused by an allergy itself? If the patient's nose is swelling up from the reaction, does that block the spray?
This is where the results were completely counterintuitive and highly reassuring. They induced allergic rhinitis with a nasal allergy challenge, a NAC. It's a simulated allergic reaction in the nasal mucosa. And this actually increased the rate of epinephrine absorption.
It increased it. The body's own allergic reaction made the nasal spray work better.
That is the leading scientific hypothesis. During an allergic reaction, vasoactive mediators like histamine are released, and these increase vascular permeability in the nasal mucosa.
They make the blood vessels leakier.
Exactly. This inflammatory state, by making the blood vessels leakier, actually enhances the transport of epinephrine across the barrier and into the systemic circulation. It confirms that the crucial early exposure, that 5 to 15-minute window, is maintained or even enhanced.
That is profound. The disease state is literally optimizing the delivery route. This finding was then tested in an even more extreme scenario, right? The anaphylaxis dog model that the EMA required.
Yes, this study was designed to address the ultimate skepticism. What if the patient is already in severe cardiovascular collapse? In anaphylaxis, systemic shock causes stroke volume to plummet, leading to extremely low blood pressure. Would the nasal mucosa even absorb the drug when the body is in severe hypotension?
A very valid question. What did the study find?
They induced anaphylaxis in beagle dogs, causing severe hypotension. The mean SBP-DBP dropped to 61/39, so severe shock.
Yeah.
Despite this extreme lack of circulatory pressure, the absorption of epinephrine via Neffy was not suppressed. In fact, consistent with the allergic rhinitis findings, absorption was increased.
So the finding holds true even in severe, life-threatening shock. The systemic release of vasoactive mediators during anaphylaxis increases vascular permeability, and that mechanism seems to override the negative effects of hypotension on drug absorption.
It provides very robust scientific reassurance that Neffy is designed to work precisely when it is needed most, circumventing those concerns tied to relying on muscle injection when peripheral circulation might be failing.
Finally, let's look at the pediatric data. This is so essential, given that children are a primary demographic for food allergies and are extremely prone to needle phobia.
This was a landmark study, the first good clinical practice or GCP pediatric epinephrine study specifically conducted for regulatory approval. It involved children aged 4 to 17 years, and they used weight-based dosing, 1 milligram for the 15 to less than 30 kilogram group, and 2 milligrams for the 30 kilograms and greater group.
So what did the PK data show for exposure in children? Was it enough?
The pediatric doses achieved very high exposure. They resulted in mean Cmax values between 651 and 690 pg/ml. Now, compare that to the adult 2 milligram dose, which yielded a Cmax of 481 pg/ml.
So the kids actually got a higher relative concentration.
Yes. It confirms that the weight-based dosing ensures more than sufficient epinephrine exposure relative to the established adult benchmarks.
But the PD data, the physiological response was, again, really interesting. Despite the children having higher drug concentrations in their blood, their FBP increase was significantly lower than what was seen in the adult cohort. Why the mismatch?
This is a classic example of age-related physiological differences, and it's not a safety concern. Expert analysis confirms that children just possess higher vascular elasticity. Their blood vessels are more compliant, more flexible.
And this greater elasticity.
It naturally mitigates the powerful vasoconstrictive effects of epinephrine. It results in a less pronounced SBP increase compared to adults whose vessels are naturally stiffer.
So a child's body handles the drug differently due to normal development, even if the drug concentration is higher. That makes sense.
Precisely. And the pediatric patients also showed some transient early decreases in SBP and DBP. This likely reflects a momentary higher sensitivity to that beta-2 receptor-mediated vasodilation before the alpha receptors fully kick in. It's just a dynamic, age-dependent response.
And the safety?
Safety profiles were excellent. Most adverse events were mild and localized, things like transient nasal congestion or a runny nose, and there were no serious adverse events reported at all.
Okay, so we have established a really robust scientific case. Neffy provides comparable or superior exposure, rapid onset, and performs well under extreme real-world conditions like congestion and self-administration. And yet, this entire pathway rests on PK/PD comparability, not on clinical efficacy trials. And this is the core controversy that critics tend to focus on.
It is the critical juncture for adoption. Critics agree that a needle-free option is better than nothing, but they question if comparable PK/PD data in healthy individuals guarantees the same clinical effect during an actual anaphylactic crisis, especially when stroke volume is compromised.
They're fundamentally asking if bioequivalence equals clinical efficacy.
Exactly. And this is where the naloxone analogy comes into play. It's a comparison that really concerns the critics.
Tell us about that. Why is it so relevant?
Naloxone, used to reverse opioid overdose, has an intranasal formulation that showed really promising PK profiles comparable to IM injection in initial studies, just like Neffy. However, when it was tested in a randomized controlled trial, an RCT in real-world emergency settings on patients who were hypoxic, hypotensive, often unconscious, those who received intranasal naloxone were more likely to require multiple rescue doses than those who received the same dose via the IM route.
So the physical state of a severely compromised patient prevented the drug from being absorbed as effectively as the initial data suggested. The PK data gathered in healthy people was, in that case, misleading.
That's the fear. The subdued physiological state in an overdose patient was hypothesized to inhibit EpiPen absorption. So critics argue that since anaphylaxis also involves profound hypotension, Neffy might suffer the same fate. They see this as strong evidence that an RCT is necessary.
Given this concern, what exactly do the critics propose? I mean, how can you ethically conduct an RCT for anaphylaxis?
They argue that RCTs comparing in-epinephrine to IM epinephrine are feasible under controlled conditions. Specifically, they suggest conducting trials during monitored oral food challenges,
where patients are exposed to a known allergen in a hospital to induce a controlled reaction with immediate access to rescue medicine.
Exactly. Under constant medical supervision. Their position is that without this definitive clinical evidence, promoting Neffy over the established standard is clinically questionable.
It's a strong clinical stance. But proponents of Neffy, I assume, push back hard on that demand, citing both adherence and regulatory history.
They do. Proponents argue for consistency. They stress that all approved EAIs were approved via the very same bioequivalence pathway, without efficacy trials. To impose a higher, different standard on Neffy simply because it's a new delivery route is seen as illogical.
And their core argument comes back to use.
Yes. The reality is simple. The only epinephrine that works is the epinephrine that the patient carries and actually uses promptly. Neffy removes the dominant barrier needle phobia, which makes the overall likelihood of survival higher.
What about the practical advice that some might give to prescribe an EAI as a backup, just in case?
That idea is viewed by many proponents as illogical and not cost-effective. Epinephrine, by any available route, has a remarkably successful history. Establishing a redundant, expensive device prescribing habit based on skepticism towards a thoroughly valid, FDA-approved device is seen as unnecessary and a waste of healthcare resources.
This brings us squarely into the economic context, which is so vital for adherence and access. Let's look at the shelf life and replacement cost.
Cost is a huge determining factor in non-adherence. The average price for a 2-pack EAI prescription is roughly $328, or about $32 after insurance. The downside is that they require replacement about every 12 months.
And Neffy?
Neffy, available as a 2-pack, has a proposed online discount price of $199, or around $25 after insurance. But crucially, it has that expected shelf life of 30 months.
So over a 30-month period, you would likely need to buy an EAI 2 or even 3 times, costing maybe $820 or more before insurance, compared to Neffy's single $190 purchase. The lifetime cost benefit is substantial.
It absolutely is. It positions Neffy as a far more cost-effective alternative over the lifespan of the prescription, which should further encourage compliance.
Ultimately, the sources really emphasize that the choice comes down to shared decision-making, or SDM, between a clinician and a well-informed patient.
Yes. The choice must reflect the patient's own preferences and their risk factors. The criteria that would strongly favor Neffy include documented needle phobia, a historical pattern of failing to carry or use an EAI, or involvement in activities that require wide temperature stability.
Like long-distance running, camping, things where Neffy's stability to 50 Celsius is a massive advantage.
For sure. And when should the traditional EAI remain the standard?
It remains the gold standard for patients who have a successful history of using it and are confident in their technique, or for patients weighing less than 15 kilograms, as Neffy is not approved for that weight class. Also, very rare conditions that compromise the nasal cavity, like prior extensive nasal surgery, would necessitate the EAI.
The key is ensuring the patient chooses the device they are most likely to use without hesitation when panic sets in.
This has been an incredibly detailed deep dive. We've covered the molecular mechanisms, the brilliant engineering of the delivery system, the counterintuitive PK/PD results, and the critical importance of human factors and economics in adherence.
The bottom line is that this innovation is disruptive. It's absolutely critical for improving community-based anaphylaxis care. The entire research pathway, focusing on proving comparability under these challenging real-life conditions, like self-administration and congestion, it validates the necessity of finding alternative, needle-free delivery routes.
The Neffy approval really highlights a scientific breakthrough aimed at solving the greatest hurdle to saving lives: patient compliance.
Exactly.
So to summarize for you listening, Neffy provides greater overall exposure than IM auto-injectors. It achieves physiological effects within a minute, and it functions robustly even when patients are congested or administering the spray themselves. This represents a huge leap forward in usability.
And this brings us back to our final provocative thought for you to consider. We spent some time detailing that surprising finding from the anaphylaxis dog model. In the state of severe cardiovascular collapse and hypotension, the body's own massive inflammatory response, by increasing vascular permeability, actually seemed to enhance the intranasal absorption of epinephrine.
The disease state itself optimizes the drug delivery.
Precisely. So, given that the physiological state of anaphylaxis seems to actively enhance the effectiveness of the intranasal route, does the weak PK/PD correlation data that was gathered in healthy subjects truly limit our confidence in its efficacy in a genuine emergency setting?
It raises the question of whether, by relying on healthy volunteer PK data, we might have potentially been underestimating the real-world performance of Neffy all along. Something to mull over until the next deep dive.